I understand you have been doing this in English for my benefit, so I'm very grateful. I've learned a lot from the first two talks. I too will try to be as interactive as possible. So if you have any
Great.
questions or anything crops up, please do just stop me and shout. Um, as you've heard, I'm going to try and talk to you about neurovascular lesions of the conus and cauda equina and touch a bit upon how rare or otherwise they are. As you've heard already, I'm a consultant neurovascular surgeon at King's. We have a fairly large catchment both for general neurosurgery, and we're quite an active neurovascular department. So we see a good volume, I should say, of these cases. But as you all know already, they are pretty rare. So I suppose in answer to that very simple question, it is tempting just to say yes and take a step back and end my talk. Because I think it's a bit of a trick question in many ways. Um, these are undoubtedly rare abnormalities. And the other thing about them, in my opinion, is that it's a bit of a beast of a topic. And I have to be completely honest, all this many years into my career, it's one that I find difficult, and they are difficult to interpret and difficult to manage. So I'm hoping today just to go through to touch upon the classifications and then what I think is actually at the root of understanding this particular pathology, and that's the anatomy, and perhaps touch upon a little bit of the embryology from an idiotic neurosurgical perspective, but a tiny bit of the embryology that results in these particular type of lesions, and then talk about how these patients present and a little bit about how we go on to manage them. So I thought I'd define neurovascular to start off with. I'm actually going to try and make life a bit easier for myself, in that I think we're primarily leaning towards vascular malformations or lesions associated with or adjacent to the neural tissue. But of course, neurovascular technically would cover epidural hematomas, subdural hematomas, spinal artery infarction, venous infarctions, all of which are undoubtedly also rare. And even within the vascular malformations, I'm going to narrow it down even further and talk to you a bit about aberrations of vascular connection, whether that's fistulae or vascular malformations proper. So, what do we know so far? And this is where I think I provide myself with a bit of, again, I'm reassuring myself that since 1971, when we first started talking about um, uh, spinal cord, I should say, spinal cord and cauda equina neurovascular phenomenon, we have had a bunch of neurosurgeons and interventional neuroradiologists every few years think that they figured it out. As recently as 2021, we've still been trying to figure it out. And you can see that the method by which they have described these abnormalities, whether it's angiographic or anatomical or a combination of the two, continues to change. And I think what that probably tells us is that we haven't quite, as a community, understood what these abnormalities are and how to group them together appropriately in order to target management of them. But ultimately, we have a well-established system now, that I think is probably the picture that you have on the right-hand side, which is from a paper that summarized dural arteriovenous fistulae and did a systematic review. Divides them according to a combination of the Spetzler and the Takai classification. So you have the most common, and that is the dural arteriovenous fistula. The next one that approximates most closely to what we all know as an AVM in intracranial terms, so essentially a nidus within the neural tissue itself. And then we have the type 3, which is the juvenile AVM. And this is the one that is probably really plays upon that embryological origin, because this has vascular components or features that can be seen within the skin, the muscle, the bone, and adjacent to the neural structures. And then we move on to the perimedullary fistulae, which various groups have divided into A, B, and C. And primarily this relates to the number of points of fistulation over the pia, and also helps categorize as to which type of treatment, either surgical or endovascular, may be best placed to treat them and get rid of them. And then finally, we move on to the epidural or extradural arteriovenous fistulae. So, where do we begin? I suppose this is where we begin with a worm, and I don't know, we probably haven't got the ability for any of you to shout out as to why I'm starting with this, but ultimately, we're taking this back to basics and the fundamentals of trying to understand why these abnormalities develop in a particular way. And I think that is key to trying to decipher them and unpick them when you see them in angiography. And ultimately, it comes down to the metamere. The metamere, as you know, being a repetitive structure. And we have very similar representation within the human form, most typically represented within the spinal column, and in particular, the thoracic spine being a very good example. And ultimately, with the thoracic spine, we know that it has the various structures, whether it's the vertebral body, the rib head, the nerves, the muscles, and dermatomal representation of each particular level. And key to the understanding the spinal vascular malformations is understanding that each segment, each metamere, has a very particular irrigation, a segmental irrigation associated with it. So, again, I'm leaning heavily on neuroangio.org, which, if you haven't seen it, is an excellent resource for understanding vascular anatomy and has lots of cases. I have taken a bunch of these schematics from that, and I'd highly recommend having a look at it if you haven't already. But ultimately, in the early phases of embryological development, we know that the neural tube achieves its nutrient supply as it grows through diffusion. But at some point, it outgrows that diffusion, and you start to develop a vascular system. And that applies to both it applies to the entire neural tube and therefore the spinal cord as well. And ultimately, in the early phases, you have paired aorta. So you have both dorsal and ventral paired aorta, which supply the spinal cord. And so you have this very typical vascular supply that's represented throughout the body. You have longitudinal blood vessels with transverse segmental blood vessels. Over time, as the vascular system continues to develop, you start to get longitudinal anastomoses between the transverse levels. And you can all imagine the direction of travel of this particular longitudinal anastomosis, which we should see on the next slide. So eventually, you have the formation of what is the anterior spinal artery, becoming the or originating from longitudinal anastomoses between these transverse segmental vessels. At each level, you also have blood supply going off from these aortae to the ribs, muscle, etc., etc. And we continue to get progressive development of this vascular system. And over time, you have a maintained longitudinal vessel. You have regression of the segmental vessels. And I think the two terms to remember when we're talking about spinal neurovascular malformations are the discrepancy between a radicular artery and a radiculomedullary artery. So the radiculomedullary artery go on to irrigate the longitudinal vessel. And these happen every so often. Many of them also regress, as is the case here. The most dominant of which we're all aware of, or the one that we most commonly refer to, the artery of Adamkiewicz, is a good example of a dominant radiculomedullary vessel. The rest of them are radicular vessels, and these radicular vessels irrigate the nerve roots, the dura are associated with the nerve roots and other structures, but don't go any deeper than that towards the medullary structures. So ultimately, this is what you're left with. You will over time lose your paired aorta, and you have a single aorta which is irrigating bilaterally. And these segmental vessels will emerge from the aorta and irrigate the left and the right. And so this schematic, again, from neuroangio is what we need to keep in mind. And I suppose, going back to the title of this talk, one of the things that I wanted to bring out with this schematic is, here is your very big aorta, giving you lots and lots of blood supply to the structures within the thorax and the abdomen. Above, you have your vertebral arteries taking over some of the role of these longitudinal vessels. And below this level, you have fairly sparse, scant vessels, which are smaller, not tiny, but small, such as the median sacral artery, which is a continuation of the aorta. And we'll come back to why that's important when we consider the question at the beginning and bring this back to specifically conus and Cauda Equina vasculature. The other big take home from my talk, I hope, is that actually, for the most part, our concern, and I think I'm talking to just surgeons and not a combination of surgeons and interventional neuroradiologists, but just for surgeons, the concern is the veins. So when you think blood vessel problem in the spine, actually you have to reverse what we normally do, because we primarily like to think about the arteries, but our understanding of the veins and the venous system is actually just as important, if not more important, in the context of spinal fistulae and AVMs. And broadly speaking, the spinal venous system can be broken down into intrinsic, extrinsic, extradural, and external. So the component parts of the intrinsic system can be seen here within the cord itself on this schematic, and you have what are considered centripetal veins that will drain the grey matter primarily towards the excuse my son, towards the median central veins, for example, which drain centrifugally towards the extrinsic system. And then ultimately, these drain via the extrinsic system into the extradural system, which have anterior and posterior components, and then further out into external systems. Ultimately, the venous system is a capacitance system, much like in the brain. Approximately 75% of the blood is sat within the venous system of the spinal cord. And so there is a huge amount of give and resistance within that system to allow for problems that may occur. And it is a reason why very often problems associated with fistulation present really, really late. So the veins are able to cope with that pressure differential that we all know occurs up to a certain point until symptoms get really, really bad. Much like the arterial supply to the spinal cord, the venous system, as we know, if we look at this image on the right, also becomes more sparse the lower down you go. So as you head down towards the conus and Cauda Equina, there are radicular veins associated with each nerve root. And this one here is one that we've kind of touched upon, and I'm going to show you a video that's going to make both of my colleagues annoyed with me. The vein associated with filum terminale in just a moment. But those are all draining conus and the Cauda Equina. So now that we've covered what I hope are the basics of the anatomy, and if there are any questions with that, do shout now. we keep all of that in mind, and then I'm going to revert to some clinical cases. And I suppose the question is, why does it matter? Because it's so rare. And I think, as we've already heard in the two preceding talks, this is a really important part of your neural system because symptoms associated with it are often really profound. So we have a mixture of upper and lower motor neuron symptoms. We have symptoms that are related to the sphincters and can be really debilitating for patients. The other thing that I wanted to touch upon here with this gentleman who was in his 50s, came in unable to walk with very little signs of any vascular abnormalities on this scan, and we'll come back to other scans which show the typical vascular abnormalities, but very little signs of vascular abnormalities. So you can imagine when the team that scanned him for these symptoms of problems with his gait, problems with his bladder and bowel dysfunction, he went on and down a particularly long path. So he had his first scan here in November 2024. And actually, relatively speaking, his last MRI scan before referral to us was in August 2025. The data suggests that the time from onset of symptoms to diagnosis of a spinal vascular problem is 18 to 24 months. So often these patients precipitously deteriorate until they eventually come to a neurosurgeon. And there are a few things that happen in the intervening period. He's had PET scans. He's had his brain imaged on the basis that this may be a demyelinating process. And he's had some steroids. And the data also suggests that steroids in the context of a spinal dural AV fistula often result in a deterioration for patients. So then he comes in and we take into context this pathology, and we think actually maybe there are some scant signs of blood vessel problems here. I really hate this bit because the next bit is almost as bad as presenting to a bunch of Greeks about words like metameres. I'm now going to have to say some French words, which is even worse. So we have to remember that the other way these patients present is with potentially a necrotizing myelitis secondary to venous hypertension, which is given the term foie à la quinine. And the other French term is coup de poignard de Michon, which is a stabbing-like pain in the back, which represents subarachnoid hemorrhage from these lesions. I think both of those are very rare. In reality, these patients present with problems with their legs. They can present with bladder and bowel dysfunction. I think what's interesting, given what I've just said about the 18 to 24 month average timeline to presentation, is that unlike Cauda Equina syndrome, secondary to a disc, because this has been a slow process that is primarily driven by venous hypertension, actually surgery even after a delayed onset of symptoms can result in an improvement in patient symptoms, even those symptoms that we typically, in the context of Cauda Equina syndrome in the UK with disc disease, think aren't going to respond. In the context of spinal vascular malformations, and in particular fistulae, they do tend to respond. So what we do now at King's is we use a scan called a twist scan or a trick scan, which is a time-resolved scan that is essentially like an MRA for the spine. And the reason we do that is because it can give us some early indicators as to the level of the pathology. So it might suggest to us one or two particular levels, and then the radiologists can target those levels with their imaging that they need to do, which ultimately is the gold standard imaging for any vascular lesion, and that's catheter angiography. The benefit of having the tricks is that it narrows it down and we don't have to do all of the levels. But essentially what's happened here is that the segmental artery is being injected. And what we can see here is the intradural fistulation that ultimately is irrigating the coronal vein. So that what we describe as a serpiginous coronal vein is not normal, and we can see this fistulation point, this fistulating vessel is irrigating it. So what do we do? Well, as egotistical as neurovascular surgeons are, I thought I'd show you this video because it's probably one of the most boring operations we do. The key here is finding the level. So once we found the level, you can see that my bipolar has just picked up the fistulating vein, the draining vein. This is a radiculomedullary vein, a radicular vein that goes on to irrigate or goes on to drain into a medullary vein. And just caudal to it here, you can see the nerve root with which it is associated. And this is the typical finding. So what I've done here is a fenestration at the level of the pathology, and I center the fenestration on the pedicle so that you can see what we have are ultimately, that is what a 12 millimeter patty. So our opening is as limited as it can be through a unilateral opening. And once you've found it, you buzz it, and eventually I will cut it. And that's it. That's essentially the procedure done. And what we find post-operatively is that very often these patients improve. And so in most cases, as long as they are functionally, clinically better, I won't get any post-operative imaging to confirm ligation of the fistula because you have such typical findings intraoperatively that there really isn't much further to do. The other key point here is, and the difference between the way that surgeons manage this pathology and interventionists manage this pathology, is that this is a disease of the vein. All we need to do is fulgurate that vein intradurally. There have been, and I was taught various approaches to this, some of which included extradural cautery, isolation of the, so to speak, nidus within the dura, and then intradural treatment. But in my experience, I've found that isolated intradural ligation of that vein is more than enough and is all you need to do for this particular pathology. The data is also very clear as to outcomes. So a study in a meta-analysis in 2021 suggested that the complete obliteration rate with surgery sits around 96% at first attempt, whereas with endovascular treatment is around 70%. Recurrence rates for surgical treatment sit at around 0, whereas recurrence rates for endovascular treatment are at around 40%. So with a targeted surgical approach, we can deal with this pathology in a highly efficacious way that is low morbidity for the patient. So just to show you a depiction of what is exactly has happened. So this vessel B is a radicular artery. It is not a radiculomedullary artery. It's not going on to irrigate or contribute to the anterior spinal, but it's a radicular artery that irrigates the nerve roots. Here we have a radicular vein. They normally live in close proximity, but completely isolated from one another. And we think that there are possibly some triggering events that can cause them to anastomose. Those can include trauma, and there is perhaps an association with preceding malignancy. And so what's happening is that eventually you have irrigation of anastomosis of the artery, the radicular artery, to the vein. This causes a back pressure into the venous system and causes that coronal venous serpiginous vessel that we saw. And that reverses the centrifugal flow of blood that drains the spinal cord. It reverses it, and you have centripetal flow. And ultimately, if it gets to its worst, you can have infarction, venous infarction of the cord and conus. I hope I'm okay for time. Just going on very quickly to a second scan. And I guess the reason I show this is because it alludes to, again, to the question of what action, the reason I said it's a trick question. So here we have a gentleman in his 60s who again is showing early signs of conus-related change within a signal change. And here we can see one or two flow voids at the level of the conus. So I know what everyone is expecting, and indeed what I expected. We were going to do a tricks and we were going to identify lumbar or thoracolumbar vascular problems causing this. But actually, what we identify instead, if this will play ball, sorry, is pathology at the level of the cervical spine. So again, a bit of a cheat on my part, but I thought I'd throw this in there because it highlights a very specific point. Conus and conus signal change in the context of spinal vascular malformations does not allow us to predict the level of the pathology. And the reason for that, again, comes down to venous outflow. We have a valveless dependent system, and therefore venous hypertension is greatest at the point of the dependent system, and in this case, the conus. So the highest pressure is exerted at the level of the conus, and therefore the back pressure is exerted at the level of the conus, and we start to see signal change there. So you can see signal change and a conus syndrome, even in the context of a much higher pathology. Now, I've given a very extreme example of that in that this is a cervical level pathology, but we typically see that with thoracolumbar disease and thoracolumbar fistulae. With this lesion, there was two isolated fistulae, both on the patient's right-hand side. Patient's left-hand side. One at the level of C2 or C12, and the other at the level of C34. Once both of those were ligated, again in the same way that I showed in the previous video, that dealt with the venous hypertension. And finally, I suppose when it starts to get really quite complicated, this 18-year-old girl was about to start university, and then she presented with sudden onset lower back pain, weakness, and bladder dysfunction. And we see these very typical but non-diagnostic flow voids on MR imaging. So we just get the sign of a busyness, and at this stage, I don't know necessarily what we're dealing with. I don't know whether this is a fistula or an intrinsic cord AVM, or it could be a perimedullary fistula. So what we need to do is go on to do some angiography, and this is what we start to see. So just to track that back, what we can see here at the level of L2 on the left-hand side, something is filling in this coronal vein. And again, we've injected on the right-hand side at the level above, and we can see something else, another point of anastomosis or irrigation of this vascular abnormality. So here's what we did. This is a long video I'm going to skip through, expertly edited for me. So, and this is where it gets complicated, because I think this is a type of pathology that before this young girl presented to me, I dealt with once before, to be completely honest. We sequentially try to identify the radicular feeders. We I agree. I then use techniques whereby, in order to understand the angioarchitecture and irrigation of this, I will sequentially clip off vessels whilst utilizing intraoperative neuromonitoring. And then it was a case of trying to understand which neural structures were particularly associated with it, and which of the irrigating vessels could be taken down when. And it was really a process of, and I'll come back to that in a second. It was really a process of trial and error in many ways, more so than I would say with an intracranial lesion. At this point, it was tethered and I wasn't able to mobilize it. And so, as is often the case, I elected to ligate phylum and phylum's associated vein that may have been draining this abnormality. This technique, to be fair, before we get onto that, that technique for ligation of the phylum vein, and the reason I said my colleagues would be upset with me, is that when we struggle to find the point of fistulation with a dural AV fistula, we'll often ligate phylum and its associated vein on the basis that it can be a point of fistulation when we struggle to see something obvious to us on the angiography. So this was the first of a few ICG checks, and clearly I've made no difference to this conus lesion. It's still filling briskly, but we've given it enough time so I could confidently take down some of those vessels that had been clipped and continue the search now for other irrigating vessels. And again, now we found another one, and sequentially having taken that down, we can see this has slowed down the irrigation of the abnormality. It's not shut it down completely. It's just that it's slower in its filling. And as you can see, you know, I agree, phylum and can have function, and therefore what we did was left the clip on there and watched the monitoring for a period of time before progressing. And then this allowed me to mobilize the abnormality cranially and look for irrigation deep to the vasculature. And we're just mobilizing it from the depth now, trying to identify any more points of irrigation. And essentially, by the end of the case, it was pretty much pedicled, and it's shut down further. It's pretty much pedicled on a point that's going into conus. And what you can't appreciate when we look at snapshots of ICG, I suppose, is the fact that it's dynamic, and we can make an assessment of the duration, the time interval it takes to fill that abnormality. And ultimately, I felt that it was not safe to try and dissect a venous varix out from conus itself. And so we coagulated a stump that was heading into conus and disconnected it, on the assumption that what we'd done is the remainder had been treated like a glomus tumor, a glomus AVM, and therefore what was likely to be happening is we have performed an in situ disconnection for that part. As long as we've taken out the irrigating arterial supply, the vein will collapse down and no longer be problematic. And we've got, in this case, because it's not so straightforward, post-operative angiography that confirmed that it was no longer there, and indeed a delayed MRI scan which shows a reasonable volume to the conus without significant atrophy. The patient post-operatively has been able to return to walking. She continues to have bladder dysfunction, but is able to now intermittently self-catheterize as opposed to have an indwelling catheter, which hopefully is a reasonable quality of life. But obviously for an 18-year-old girl, that's not ideal. So those were just the three cases that I wanted to highlight. Returning to the original question, well, I suppose I have to defer to the knowledge of individuals who've done this a lot longer than I have and seen a great many cases. So we looked at I looked at the case series for Michael Lawton to try and understand how many of these cases does a prominent neurovascular surgeons see. This case series, as published in 2018, had only, I think, 45 spinal dural AV fistulae. So that's how rare they are. Over the course of his career, he'd only done 45. And so it undoubtedly is a very rare pathology. And I think when you start to move into the more complex lesions, whether that's perimedullary fistulae or glomus AVMs, those are really vanishingly rare. And many of us will only see a handful of cases over the course of our career, which is why I think it's so important to be able to fall back on the established embryological and anatomical knowledge that we have, because that's how we would unpick them and really be able to treat them in a safe manner. That's the end of my talk. Thank you to Mr. Barkas for inviting me, my friend and colleague for many years, and I'm excited about our collaboration across both of our institutions at King's. I think we've been really successful with it. We've had Yorgos, who's back in Greece now, and Yanis is with us now. It's been really positive for both our unit and hopefully yours, and I look forward to doing more of it. Thank you. Do you have any questions at all?
Okay, thank you so much, Achilla, for your. So, I mean, it was very nice, your talk, and very. I mean, you gave us the picture of the AVMs from another point. I mean, I must admit that it's very rare, as you said. So just to share with you my feeling, do you feel that AVMs, I mean spinal malformations, are more treated by surgeons than intracranial ones?
I don't know. I think it depends. I think it depends on unit. We do a large volume, I should say, of intracranial AVMs as well. I would say that I think universally the tendency is to move a higher percentage of spinal vascular malformations towards the surgical route than the endovascular route in King's. That continues to be the case, and I think that centers around the recurrence rate if we're just talking about the spinal dural AV fistulae, for example, we still consider that surgical pathology, and the most effective thing to do is surgery for those at King's. But there are other units in the UK where they will primarily be treated through endovascular means. But in my opinion, the data does not support that. I think it's a low morbidity operation that can be done quickly, simply, and with very, very low recurrence rates. So I think that is a surgical pathology ultimately. And we shouldn't lose the ability to do it. I think that's the key. I think that's what's happened in lots of places.
Right, thank you. Is there any question?